Hello, my name is Navpreet Dillon, and I will be presenting a case report on familial hypocaloric hyperglycemia. So this is a rare genetic disorder that affects calcium regulation in the body. It causes both hypercalcemia and hypocalciuria. So the mutation that results in the disease is on the calcium sensing receptor gene. This gene is located on chromosome 3, and it primarily affects the calcium sensing receptor, which is located on the parathyroid glands. So, the calcium sensing receptor is responsible for detecting levels of calcium in the blood, and it regulates the body's response to calcium changes. So, that's where we see that this gene is important in regulating calcium homeostasis. Now, when calcium increases, it causes the receptor to signal the parathyroid gland to decrease a parathyroid hormone secretion. So a reduction in PTH hormone lowers the calcium levels. But when this mutation occurs, it results in a lower sensitivity to calcium. This genetic disorder is autosomal dominant, and it has no sex preference. It's 50-50 for men's and females. So getting to the case report, this patient was a 24-year-old female who had no notable clinical manifestations. Um, and during a routine checkup, she was diagnosed with hyperglycemia. The patient gave a non-detailed family history of hyperglycemia. All her vitals were normal, and she presented at the clinic for the unexplained chronic hyperglycemia. So patients with FHH generally are asymptomatic, like it was in this case. And it's so the lab did a little bit testing, and we see here the patient had high serum calcium levels. She had normal levels of alkane phosphate, and she had normal levels of phosphorus and magnesium as well. But there was a high serum PTH level, and there was also low levels of vitamin D3. So upon further investigation, um, it was discovered that the patient did actually have a relevant family history of hyperglycemia. The patient had two children who were born with high levels of calcium, and she did not initially state that to her providers. So then it was decided that her family should also get laboratory investigation. So the patient's father, the patient's sibling, and her three children all received laboratory testing. And we see that the patient obviously has a high level of calcium. Two children, the two twins boys that I said were born with it, also have it, and her daughter, who was not tested initially, also have it. So we can go back here and we can see that the normal range of calcium is 2.18 to 2.58. So everyone in her family has a high level of calcium. So this resulted in the physicians deciding to do a little bit of genetic testing. So genetic testing was occurred for chromosome 3, Q at the locus of 21.1, and it was discovered that there was a defect in the castor protein gene. And as I said, it is autosomal dominant, and it affects the amino acid substitution altered protein function. So, um, Upon the main differential diagnosis that occurs with FHH is with primary hyperparathyroidism. And that is due to both conditions presenting with hyperglycemia with a normal elevated parathyroid hormone. So how you differentiate these two diagnoses is with the genetic testing. So FHH will present with that mutation in the Cas gene located on chromosome 3. The main thing is that patients with FHH do not require treatment. The main goal is to monitor calcium levels, so to have regular checkups to make sure that they are not leading to symptomatic levels and to avoid unnecessary treatment. It is also important the patients ensure adequate fluid intake. And in certain symptomatic cases, which is very uncommon in FHH, patients may be started on glycemic medications. So the main thing I wanted to discuss in this case was that initial diagnosis of FHH was mainly delayed because there was not adequate family history regarding the patient. When the patient first was seen prior to the initial diagnosis of hyperglycemia, the patient did not state that members of her family, which she was only aware of her twin children, had a initial testing that showed of hyperglycemia. Now, this may be due to a variety of reasons that she did not remember, she did not find it relevant, or that she just did not have the health literacy capacity to understand the importance of it. The family history was actually discovered through communication of various clinicians and previous notes that showed that she did have a family history of hyperglycemia, and which led to further testing to discover that it was FHH. And so, if FHH was not diagnosed, she could have been treated for primary hyperparathyroidism because it obviously does present with similar symptoms. So I think the main thing to learn from this is to ensure that adequate information is presented and to ensure that there is a detailed family history for the patient and to really make sure that they understand what that means. Because in certain cases, it can lead to inadequate diagnosis, which can lead to inadequate medication, and which can cause worsening of symptoms, or in this case, could cause symptoms. Thank you very much for listening. Here are my references that I used in this discussion, and that is all.